Well, good morning, everybody, and welcome to this Healthcare Innovation Consortium EPR Network InsightHive webinar series. For those of you that don't know me, I'm Hadley Stoller. I'm the Chief Executive of Healthcare Innovation Consortium. I'm thrilled to be joined today by David Brown, Managing Director at Clio Systems, Dr. Paul Perry, Medical Director at Clio Systems, and Nikki Hookins, Senior Manager and Registered Midwife from Capgemini. So I'm thrilled that you've all joined us today. This is the first of 6 webinars over the next few days, but we'll come on to that after some housekeeping. So just to let everybody know, everyone's video and audio will be disabled, but you can, and we encourage you to post questions and comments and insights, etc., into the chat function. So please do use that as a way of communicating with us and kind of getting any questions that you might have across. This session is being recorded, and within the next few days we will send you the recording. So hopefully you can listen and don't have to worry about taking notes, etc., because we'll send it to you. So just a little bit about who we are and what we do. So the Electronic Patient Record Network is hosted by HIC with support from our strategic partner Capgemini, who are on the call with us today. This is about the discovery, the implementation, and the success of EPR implementation, defining what that problem is, delivering it with the people using it, and then improving after go live. And we're thrilled to be working with a number of organizations across the country. And if you want to find out more, obviously you can get in touch offline. Next slide, please. Thank you. So this community, is more than just a group of suppliers. We aim to publish lots of things like white papers, running the webinars like we're doing today, and other activities. And in partnership with Convenzi's group, we host 4 summits across the country each year. We had our England summit in February, but on the 8th of September, we'll be in Scotland. On the 15th of October, we'll be in Ireland. And on the 18th of November, we'll be in Wales. So please do come and join us if you can. That would be awesome, and it'd be great to see you in person. So I did briefly introduce people, but hopefully you can see, obviously myself, David, Paul, and Nikki. They're our panelists today. The one thing that I should just mention is that this is, like I said before, this is the first of 6 over the next few days. If you'd like to come and join us for any of the others that are taking place over the next few days, I think the link will be in the chat shortly. Please sign up, come and join us. It'd be great to have you with us. So yeah, without further ado, I'm going to kind of bring our panel into the conversation. As I said before, for those of you that just joined, please use the chat function as a way of communicating with us. And yeah, thank you very much for joining. So David, Paul, Nikki, what we want to talk about today is optimization versus innovation, and where to focus energy and why. So, when we talk about optimization, and I know that word means lots of different things to different people, including innovation, but when we're comparing the two, in healthcare, are we actually talking about different things? And actually, how do you define optimization, and how would you define innovation? Maybe I come to you first, Paul, just to give your insight into that for us. That'd be great.
Yeah, that's great. Thanks, Hadley. I think for me, they're both, and that's the important nuance, really, isn't it? Optimization is about getting the best out of what you already have, so making systems safer, smoother, and more usable for clinicians and patients. Whereas innovation, on the other hand, is about introducing, something genuinely new that changes the way care is delivered. But I think in reality, they sit on a continuum of digital maturity. And so you can't really meaningfully innovate on top of broken or poorly adopted systems already. And I suppose in my background, general practice, what I see particularly is innovation that succeeds only where optimization has already created that trust, usability, and the reliability that goes with it as well.
Yeah, no, absolutely. Thank you. And we'll maybe come on to some more of those examples later on, Paul, as we're talking. David, I don't know if you want to come in and add anything to that from your perspective.
Indeed, I think there are definitely parallels between the two, and from the opportunities, as Paul mentioned, around optimization and innovation, and those aspects being able to be digitally enabled and support patient pathway redesign. In framing innovation, I see it as potentially unpredictable. It's not necessarily timely. I've definitely had experiences of innovations that have taken years to
Mm.
be adopted, etc. And also from an optimization point of view, they're easier to be measured. They're easier to demonstrate an iterative kind of improvement over a period of time. And so having QI initiatives that are frontline led are really exciting because we can really identify those opportunities, but sometimes they seed innovation in the same line.
You used another word there, David, which was really interesting, which was adoption. And that's an interesting one, isn't it? But not to go off too much on a tangent, but actually, bringing in a technology and saying it's gone live, it's been adopted, but actually that just means it's there, doesn't it? But it
Indeed.
doesn't necessarily mean it's being optimized, and optimized, means full scale rollout in my mind, and then being able to bring in that innovation. I would argue you can't really innovate properly and truly unless you've got a fully optimized system, because that's where the
Yeah.
innovation comes from, doesn't it? Otherwise, you're always playing catch up, right? So that was an interesting word you used there, just kind of triggered that in my mind. So, Nikki, I don't know what you want to come in with here, particularly, I guess, maybe around another different clinical lens as well, possibly.
Yeah, so as most people probably know, if they've had a conversation with me, I tend to break technology. So any kind of technology is not the most natural for me. I'd always find different ways of using technology. And when you're working clinically, never necessarily got the time that I needed to kind of get used to using it and making sure that I was using it correctly. And having bells and emergency bells going off kind of does affect what you can do and how you use it. So when I was thinking about this, like, question, the difference between optimization and innovation, I think both David and Paul have kind of given it's a circular kind of improvement kind of cycle with what we're looking at. I think from my perspective and from experience is that we're very good at doing like discrete silo type work and kind of bringing in different systems, and then it doesn't scale, and there's always really complexities around the scaling. So you think it should be simple, but there's lots of non-technical potential issues, but also technical issues potentially, depending on if you have different systems and how it's configured and you're working across sites. There tends to be issues that are resolvable, but it takes a lot of time, and the kind of factoring in the people side and the time and energy it takes. I'm sure, Paul, from a general practice perspective, the amount of times you would have got suppliers or NHS England or someone coming to you saying, oh, do you just mind trying this one thing? But it's one thing of like loads of other things that don't necessarily join up, and the amount of time and energy that is taken up. And by doing that, and it's not only that, but it's your citizens, your patients and things like that really get affected. And I think one thing that I'm really kind of challenging myself and challenging other people at the moment is around innovations everywhere and in lots of different industries. So how do we accelerate it in our health system, and how do we bring everyone on that journey in doing things in a way, like, we don't have to prove certain things, they're already proven in other areas, but how do we use it to accelerate rather than kind of go back to square one with what we're actually doing, and actually use it as a way to speed things up and not have to duplicate certain things. Obviously health has nuances to other industries, but there's things that we could potentially think about it differently to actually, when you're needing to talk to the clinicians and you're needing to talk to the users, you're doing it in the way that has the most value rather than just kind of going back to the basics.
I think one of the points you picked up on there, Nikki, is around training, isn't it, and awareness and understanding actually what those systems are, and because in order to optimize something, you need to know A, that it exists, and B, how to best optimize in clinical practice, so that day to day becomes easier, because technology should be an enabler, shouldn't it? It shouldn't be an additional stress and an additional set of activities. It should take away old ways of working and replace it with a new way of working.
I did my own little PDSA type cycle when we brought in clinical notes when I was working clinically, and it probably saved me about 2 hours from hunting notes, trying to find notes, find out what the registrar or one of the doctors had said, like for some of my patients, because notes maternity you have, especially in the postnatal side, it did save a lot of time, but it was still painful going through that process. And I was, even though I know all of this, I was still, you know, I want my bit of paper back that I was writing on when I was doing it. So it is normal to have that kind of process, but it's kind of teaching people how to go along with it and what you're doing to then make it easier for them, which I don't think is always easy.
It's that cultural change as well, isn't it? I mean, you just reminded me, Nikki, and I don't know if the team could maybe put this in the chat, but there were a couple of white papers that the EPR network recently published. One was around the optimization gap. And one of the recent ones was, why having an EPR doesn't mean, isn't the same as using it well. That was the title. So, I think we recognise that cultural change, and that kind of, those organisational challenges, barriers, etc., that need to be overcome. And I just wondered, I mean, maybe David, I can come to you. Do you think that, particularly when we're trying to innovate, do you think innovation is the same? As optimization, but just kind of with better marketing? Is it just about how we get the same message across in a different way, or is it actually different? What do we mean by trying to innovate whilst also optimize?
I think it's a really interesting question, and I feel that there are definitely parallels, and I guess the context on this is where I reflect on the introduction of electronic prescribing into secondary care outpatients and also into community pharmacy. And as an example of it being an existing technology, existing capability in general practice, but it's certainly optimized the journey for patients, and also the reduced aspects for the clinicians and the safe administration of patient medicines. Was that optimization or was that innovation? And therefore, in other contexts, I see that we have used innovation to enable optimization. So introduction of kind of speech analytics or text analytics and the ability to have access to repeatable data that you can identify opportunities for optimizing processes, etc. And that was kind of led and braced around the introduction of new capabilities, and also the faith that something good and capable would come of the introduction of that technology. So I feel that innovation and optimization, I suppose I wanted to avoid the response, it depends.
Yeah, it depends. Yeah, no, I get it. I mean, I just wonder whether we've are we, because just listening to you, Paul, your primary care experience, then what you were saying, Nikki, around reverting to old ways of working, do you think that we're maybe becoming too focused on launching new things, because this is part of the optimization bubble almost, isn't it? Or are we actually needing to improve what already exists? And you could argue that is perhaps being innovative, but actually, do we just need to get the basics right and just use what we've got and use it well, instead of focusing on the next shiny thing, that's coming down the track?
I think it's both, and I think Karen in the chat's kind of put around understanding, and I can definitely relate to that, and working with other clinicians, understanding why you're doing certain things. So I'm going to admit on here that, when I was using an old PAS system, there's certain things you just kind of click, be like, oh, this is just the quickest way to do certain things. It wasn't until I went down, doing kind of the auditing and that management and looking at clinical, like from a governance perspective, it wasn't then until that light bulb moment went, and I was like, oh, this is why we need it. This is why it's important. And I was doing, what the university that I trained at, I was doing something with the third years around this kind of innovation and digital transformation piece, and I was like running through it, and I had to check myself. When I first started, I was using all these words that I had to learn. It's a whole new language, and actually I had to take myself back to say, actually, people aren't trained in certain types of lingo. They don't necessarily understand it, so it's actually, what does it mean to them and why do they need to do it? And I think if you spoke to most clinicians, they want what's best for their patients, their users that they're working with. And if they understand what that is and how it impacts it, and what does it look like overall, you know, from a logical perspective, they'll get it, but they need that infrastructure around them and understanding around what they need to be able to do that in a safe environment, and not, you know, come onto a shift and they're short staffed, someone's off sick, they have their acuity of patients is just getting higher and higher, and you're then bringing something new. It doesn't create an environment where you can do that. And then the other thing is you just keep adding more and more layers. So Hadley, when you're saying around the piece around do we need to use what we've got, but we just keep adding layers and layers of new things, but not taking anything away, and then it just kind of, we just have to find workarounds and find our own ways of doing things, then it impacts that, you know, that user or other clinicians further down the line.
It's counterintuitive, isn't it? Because whilst you're trying on one hand to innovate and to bring in better ways of working, on the other hand, you're potentially kind of stopping things and causing issues, right? So, I mean, I guess, Nikki, you know, if you had to choose one, I think I know what your answer will be, but if you had to choose between optimizing what's already there, and I agree with Kaz's point absolutely about the training, but if you had to choose between, you know, optimizing what you've already got or kind of innovating with the new stuff, you know, which would you choose, and why?
So I'm always one of those people who wants to look at how can we do things, what can we do differently, but I think different moments in time you'll say different things. But I think at the moment, the way that everything's going, I think there is that stabilizing, getting people confident with using technology. I think most people know from the clinical perspective, there's like a lot of research from the nursing and midwifery side around that. Nurses and midwives know that technology will be beneficial and will help them, but it's not currently improving their productivity. It's not currently improving what they're doing. They're kind of that in-between person around it. So I don't necessarily think anyone's like really getting what we need to do. We say training, but what does that actually mean? It feels a bit of a tick box exercise, I'd say, at the moment. But how do we need to support our frontline staff to understand, but also be able to use things well, if it's useful and usable? And I think seeing other industries, we look at our phones, our bankings, they're making our lives so much easier. Like, probably showing my age, but I remember when I'd have to write all my mobile numbers down in case something happened, and now that everything just like transfers. So there's going to be lots of people who are growing up not having to do that, and everything's just so seamless when they like change a phone or something happens, and you can do your preferences, and we don't have that in health tech. So everyone else is getting used to that, and in health tech we're still way behind the time, and it's still really, really painful doing anything. So
yeah, no, I get that. I remember those days as well, Nikki, so I'm not far behind you. Paul, what do you think then in terms of that? Yeah, if you had to pick one, you know, which do you think you would go for?
Yeah, I have to say I was reflecting as well, thinking Nikki's brought back a lot of memories for me as well. I mean, I think for me it's optimization, isn't it? I think not because innovation is not important and, you know, we don't have the ability of the tech there, we do, but I think because across most healthcare organizations, we're still not fully realizing the value of currently what we have. You know, we've got multiple systems that are built on other systems. So I think from a GP perspective and even a safety perspective, I think, you know, clinicians, as Nikki said, we're constantly working around, I suppose, just finding those workarounds for different systems that we currently have. There's lots of variability in the tools and applications we have as well. And often by having multiple different systems, you just introduce friction and that clinical risk. So I think ideally it would be, for me, optimization, getting the highest return, but the lowest risk investment, I think, right now for the NHS.
No, it makes sense. And investment is a good one, because I think, you know, what I kind of want to talk about now is, you know, constrained resources and where we focus, you know, our attention. So, I mean, you know, Nikki, maybe I'll come to you, and maybe Paul as well. You know, obviously healthcare teams are very stretched. We all recognise that. I think we've alluded to some of that in the conversation so far. So, you know, are organisations, do you think, spreading themselves too thin to optimise existing systems, whilst also kind of chasing that, you know, that innovation pipeline? I mean, obviously as an example, you know, to bring in an EPR is a huge undertaking. But it doesn't just happen on day one. There's a continuous implementation of new modules, new features, new departments, new capability, you know, etc. So you know, are we, you know, yeah, are we spreading ourselves too thinly? Maybe come to you, Paul, you know, just to ask initially what you think on that.
Yeah, I mean, I think we probably are. I mean, in terms of workforce and I suppose the constrained resources there, I think for me, innovation often outpaces the operational reality. And so that's probably one of the biggest risks. But essentially, yeah, I think we need to focus on the workforce, ensuring that, you know, we can deliver more with what we have. So
Yeah.
again, just analyzing the technology that is within the market to actually make it fit properly within the NHS, not just, again, overloading the system.
Yeah, and Nikki, any thoughts on that as well?
Yeah, so I kind of feel like there's a lot of buzzwords that are going around at the moment, and they've been going around for kind of years. They change depending on certain things around optimization, productivity. It was back lean a few years ago, all these different processes. So we're all saying the same thing, but it's like, what are we doing differently? And I think what's adding to the complexity is that technology is advancing so quickly, and there's so much value that can be brought into it. It's actually probably creating too much choice in some respects, where there's so many, if you go to kind of like any of the kind of conferences and you're kind of looking at, so I've been spending quite a lot of time in this kind of social care space around how, if I was a buyer and I'm looking at what I need, they all seem quite similar. There might be like nuances or focus on as like, how do I know what I need to kind of get going? And I think the way that obviously that the funding kind of cycle works and resourcing, it's like every time I've done a business case when I was in the NHS or working others, it's always you're cutting the training, you're cutting the implementation, you're cutting the change management support, and it's only for a short period of time. It's not that like ongoing cycle, and actually it's really tough for both sides, because when you're busy and firefighting and working, you don't necessarily know what you want or how to articulate it to suppliers. So you're in this kind of dance, and you know the suppliers are really trying to do what they, you know, do their best to give you what you need, and a lot of them have also been on both sides, but trying to articulate that and get it to where you need to, there isn't necessarily the time or space to get it completely right. And then I think kind of the way that our processes work, with the way that we have to do business cases and procurement and things, potentially need looking at. Obviously that's a huge ask, but around how can we improve it so that we can be not so like laggardy and actually be kind of more forward facing around, actually, you know, we can actually catch up and stay ahead and actually think about actually what's going to really improve it for kind of our clinical staff and also our citizens.
Absolutely, and thank you for that, Yvonne, in the chat. I think Yvonne says the adoption has a lot of influence on how effective optimization could be. To understand how digital systems can support clinical teams to do their work safer and more efficient is important in the training side of things, and having end user support also after digital systems are rolled out. So I think that's it's coming back to that training piece, isn't it? A lot of that, and I think, you know, just to say, just for your benefit as a panel, we've got you know, NHS representatives here from all over the country, from Cambridge to Cardiff to Essex, London, North Cumbria, etc. So I'm really interested to hear, you know, other people's views as well around, you know, what you feel, and I'm asked the panel this as well. You know, are the warning signs perhaps that those foundations aren't in place? Because I think what we're all describing here is all the component parts that make these things successful or not. You know, if the culture isn't there, if the training isn't there, if the right systems aren't there, if the resources aren't there, if the roadmap isn't there, you know, these are all the things that have been coming out of the conversation. But you know, what are those warning signs? Well, I mean, are they the foundations? That have we missed anything? But what are the warning signs if those foundations aren't in place? Because we've got lots of people from the NHS here, and you know, it might be really good to help them, you know, maybe spot some of those signs, you know, in their respective organisations. David, I'm conscious you've not spoken for a while, so I don't know if you want to come in and kind of lead the charge on that one.
Yeah, so I was a number of things that I was kind of considering on this is that, you know, in frontline teams and the impact that they have, or at least the efficiencies or lack of efficiencies have on those frontline teams, can be, you know, quite vital to ensure that we've got some awareness. Is there an ability to ensure that there is a framework that enables that communication between teams and the leaders that are invoking change, etc., and also the risks and any incidents that are occurring off the back of implementing or not implementing change. I don't know if I'm probably not answering your question on this one, but I'm just conscious that there is an effect of not having the foundations in place or the ability to have your voice heard in terms of opportunities to make change happen.
Yeah. And Paul, I guess from your perspective then, what's your view on those warning signs and those foundations that either need to be in place or aren't in place, and what that means?
Yeah, I mean, the red flags for me would come down to two things. The first one would be patient safety in terms of harm. Has the incidence or prevalence of harm on patients gone up as a result of implementing an IT system? And secondly, as well, and again, we can measure this, it's around clinician efficiency in terms of, are the tools, the digital tools that are being implemented, helping the clinicians to do their job in a better and more effective way? And again, I think by measuring just two of these things, and there are obviously more measures we could use, that would give a feel for actually how well or not so well the digital technology system that's been implemented is working.
Yeah, and I guess just to play slight devil's advocate there, then, Paul. So, what would your view be on patient safety, harm, etc., if that system isn't in place? So because obviously it works both ways, doesn't it? Do you think that's an increased risk or a decreased risk? Because obviously,
Yeah.
maybe not having these things could be far worse. I know that's
Yeah,
a
of
slightly
course.
controversial sorry.
No, you're grand. I mean, I think there's pros and cons to whether you implement or don't implement, really. And again, I just come back to patients. This is why we work in healthcare. It's for patient care. And so again, it just for me, it always comes back to that kind of end-to-end patient journey, particularly when you're, reviewing adverse events, significant events and incidents that have, encountered potential harm or near harm for patients.
Yeah.
And again, I suppose I would just see it from a systems thinking perspective when you analyze this. And there's a wealth of evidence and research that has looked at, the implementation of certain EPR platforms and applications versus actually not implementing any new technologies as well. So, but yeah, it always comes back to patient.
Okay, but so just one more question for you, Paul. Sorry, and I'm asking you a lot here, but so let's just take we've got Caroline on the call. She's from Queen Victoria Hospital, right? I think it's in London. I think I'm a bit geographically challenged. A busy trust. They've got an established DPR. There's lots going on. There's a lot of activity. Winter pressures is just around the corner, even though we're only in June. But it's soon creeping up. There's a lot of things that are coming out the trust way, lots of innovation, lots of new tech, lots of roadmap development items that are coming through from their EPR, lots of periphery innovations, and other systems, that need attention with a workforce that's stretched. How do you, how does Caroline respond to all of that when there's the day job as well? Because we're talking about the constrained, resources here, and I guess it's what do we do? Where does that conundrum kind of end?
Yeah, I mean, I suppose it comes back to kind of clinical risk assessment and safety, doesn't it? I suppose just reflecting on the NHS England's DCB standard. So, if I was a clinical safety officer in an NHS trust, I'd be thinking about how I risk assess having one system or multiple systems and how they integrate and interop as well. So I think, that's one dimension to multiple different dimensions with rolling out and using EPR digital technologies within the healthcare system. But again, it just comes down to, I think, clinical safety and that risk assessment. And I think by doing a risk assessment, it would help you further develop options and recommendations within that, very volatile, uncertain, complex healthcare environment that we work in.
Yeah, no, absolutely. Yeah, no, thank you. Sorry, I know that we went off on a slight tangent there. Hopefully that was helpful, Caroline, but please obviously feel free to put comments in the chat. David, I guess just coming back to you then. So in terms of, signals that you need to tell an organization is genuinely ready for innovation rather than needing optimization first, what signals tell you that that's the case? Obviously I've just described a slight scenario, but is that a realistic one, or are there other things that you would typically look at a trust, work with a trust to say, yeah, this is what's going on here,
Yeah, I think in terms of the foundations we've discussed, I think we need to ensure that they have been embedded, and I think it's quite tricky. And my opinion is that, as we mentioned earlier, I don't feel that this to be mutually exclusive. So having optimization, I think, can lead to both outcomes. A culture of innovation will likely derive through taking opportunities to reflect and inspire that kind of optimization, which could lead to opportunities for groundbreaking change, innovation. We're seeing how ambient scribe, etc., are being implemented within trust, but we also see where they could be expanded and utilized in other areas. So from that aspect, this could be through a culture of improvement, a strategic intent for innovation, a vision of diversification, or necessary an evolution, as well as relating to productivity or kind of cost improvement. I'm just kind of conscious that when efficiencies and there are challenges to be met, that there is an appetite or a risk appetite for change, and therefore that has to be demonstrated, and that there is psychological safety to teams be implementing that change.
Yeah, and just as a slight question, obviously from a product perspective, David, because obviously I know you've got a product. Do you find that the innovation can naturally come not necessarily from the product, but because of the product, it's almost enabled where that structure, where that foundation, where those risks are recognised, which we're in a second. Do you feel that? That can help with the optimization and innovation, landscape within an organization?
Yeah, I certainly believe that from experience in implementing a capability that provides the opportunities to have access to additional data, to have access to the ability to improve workflows, so kind of low code or no, or kind of, as I mentioned, from a speech analytics point of view, the ability to kind of profile of what you're looking for and the after effects of that change, and then the ability to implement that process. But I also feel that having the opportunity to work with clinicians and operational frontline teams and other members in a back office as well, by shadowing, you can identify and tend to identify, and ask questions as to why are you doing this, or would it be beneficial if you had X, and then having the ability to bring that to life really makes that that iterative process flow much faster.
Yeah, no, absolutely. Paul, last question, and then I'm going to come to you, Nikki, because I'm conscious you've now not said very much for a while. Where do you kind of see some of the risks then, when organizations are trying to move too quickly? Because you've got one end of the spectrum where there's not enough resources, there's not enough time, there's too much going on, but then you've got the other end of the spectrum. Has his trust in Cambridge, for example, that's trying to do a lot and is implementing a lot and has a very ambitious, innovation pipeline. So, but what are the risks of doing that? Because obviously you can only do so much with the team that you've got. So, what do you see on that front?
Yeah, I mean, I think some of the biggest risks come when innovation outpaces that operational reality, doesn't it? So, and that almost flips the organization into that uncertainty risk area. And I suppose some of the common areas I see are workflow mismatch that Nikki's touched on. So, again, David's highlighted the need for commercial suppliers to actually go into the environment that they're designing a product and solution for, understand that workflow, the end-to-end patient pathway. And as a clinician, jobbing GP that I am, often suffer from cognitive overload. So just, being very stressed, sometimes we're having to use multiple systems, and, there's lots of busy departments and services. I think the other one is hidden patient safety risks as well. And it comes back to the, clinical safety officer role around clinical risk assessment. And again, adoption gap. So I think when you implement any EPR technology or any digital technology, there's going to be a gap. So again, where something is technically live but not meaningfully used, and I think that's key. And again, as a GP, I think even small changes can have system-wide ripple effects. And again, just very mindful of, if you implement X technology, you need to be doing that risk assessment and analysis as well, because it could potentially create those unintentional harms.
Absolutely. The risk assessments and evaluations, etc., is a topic for another day. That's a whole webinar in itself. So I guess with all that said, there's absolutely something, isn't there, Nikki and panel, around, measuring value and impact, because we talk a lot about, we have talked a lot about optimization, innovation, doing things differently, building those foundations, building that resilience, changing that culture, training people. But after all of that, obviously there has to be an impact, hopefully in a positive way, around these solutions that have been introduced. So, are we sometimes, Nikki, do you think we're too focused on efficiency metrics rather than patient outcomes when, judging that success? And as a supplementary question, do you think that we're actually good and active at measuring those outcomes and benefits?
So I've worked of like implementing different types of systems, and I think the one thing that I've noticed, especially when you're kind of implementing an EPR perspective, you go through your kind of business cases, benefit realization, and then once it's delivered and you're kind of going through it, the value of what you're expecting the benefits to be, you can normally have to write a lot of money off from it, and then it's taking years and years to start to see the real benefit. And I think we are getting to a stage where we know that most organizations now have some form of EPR or system, and actually the benefits of bringing in a new system are going to be a lot smaller. So I think we're going to have to start looking at it in a different way around what we're looking at, because I always go back to kind of like resourcing as an example. So I remember when I was on the ward and things are, and still do some shifts, but you'd be like, oh, I wish we had more staff, I wish we had more staff, and that would always be everyone's response. And then I'd look at the adverts we've been advertising for people to come and work on the ward, and we're not getting any candidates. So it's like, well, we are doing what we can to get more resourcing, but it's not. So how do we need to think, and what do we need to do differently? And I think, yes, technology can be an enabler and can support it, but I think and I'm sure there's a few people who can relate to it, but one of the nursing kind of stats that they use when they're kind of looking at the digital side is 85% of the nursing community, this is one of their researchers, is that they have problems with basic IT. So from battery life, black spots, loading systems, not being able to kind of, having to click through different pieces. So how are we meant to then trust when we're bringing in new things, if we can't get the basic rights, which will have an impact? I think, yeah, it's I think there's potentially a lot we need to think about differently, because we're thinking about things in a very immature, bringing stuff into a new way, and actually we need to start looking at it, what does it look like, and actually start being honest and realistic around what the benefits and financial benefits, because the way that we do our business cases, that we have to justify it and go to the nth degree around why we need it to justify what we're doing. So there's potentially a way that we need to start looking at it more realistically to then actually get the real benefits.
Yeah. It's also, and again, this is also a topic for another day in itself, really. But it's also measuring those benefits. How many times have we all written or been part of a business case, where a lot of the benefits were scrutinised, and that was a sticking point in the case being approved in the first place. And then once the funding is approved and the system is in, who's really tracking and monitoring those benefits from the get-go? Usually it's 5, 6, 7 years later when it's time to renew that business case and that investment, isn't it? I can see Paul nodding. I don't know if you want to contribute anything there, but yeah, that's it's a typical story, isn't it, really?
It is. So I was just thinking of my previous NHS experience as well of rolling out digital technologies and writing business cases and getting a bit frustrated, if I'm honest. But it's a really good question, isn't it, around measuring value and impact? And I think sometimes, are we too focused really on efficiencies over patient outcomes? The answer is probably yes, I think. Efficiency, as we know, efficiencies, operational efficiencies can be measured with time saved, appointments processed, calls handled, etc. But from a clinical perspective, those are proxy measures, not outcomes. And so we should be focused more on patients in terms of have they received the right care in the right place at the right time? Are clinicians able to make better decisions? So these are the things that we should be, measuring, rather than writing, 20-page business cases.
Yeah, yeah. Well, 20, that's a short one. More like 200 usually, but yeah, there you go. An interesting comment actually, not quite linked to kind of value and impact, but around, but probably, indirectly from Elizabeth around user experience, UX. So do we need to address user experience, co-design with clinicians and prototyping after studying human computer interface and soft system design? It seems that this thinking is absent in her trust, and it sounds like it's absent in others. And she wonders how much of the EPR implementation model on NHS futures and arguably how those systems are procured causes bad design, i.e. not user focused, not mindful of system thinking. And can we fix the EPR model by adding a design workflow? And Kaz agrees around the focus on outcomes that we're expecting, not just on cost avoidance and monetary ROIs. So yeah, I think there's some good points there, particularly around if the system isn't useful and usable, it won't be used. So that co-design piece, I think, is a really important one. So no, that was really helpful. So I mean, I guess do you think that we're sometimes too focused on those efficiency metrics? I think this is what Kaz was just alluding to, actually, rather than patient outcomes when judging that success. I can see you nodding, Paul, and if you want to come in.
Yeah, I mean, I think we are. Again, for me, it always comes back to patients in terms of, the people, the end users that are accessing the healthcare system. And, if we're not measuring if patients have gotten to the right place at the right time, if we're not reducing that clinical risk and the variation. I mean, often when you analyze operational models, there's a huge variation really in terms of what happens with the NHS environments. And again, as a GP, is this digital technology helping me make a better decision for the patient? That, these are the outcomes we should be measuring more than ROI and, cost avoidance.
Yeah, and I mean, David, Nick, if I come to you, how do you realistically demonstrate a return on investment for optimization work, especially when improvements can feel really incremental as opposed to kind of transformational? We talk about, programs that and technologies that are going to bring in digital transformation, but it's really hard, to kind of track that, isn't it, in terms of some tangible return on investments, because those changes tend to happen, incrementally. So yeah, I don't know what you think, David, if you want to come in first on that.
Yeah, so with the experience that we've had within the urgent care settings, as an example, we've been able to target particular optimization aspects of a clinical pathway. So as part of supporting that, we determine for the size of organization and the episodes of care, etc., how the proportion of the time saving or efficiency or reduction in cognitive burden to the clinicians would be supported in terms of outputs in relation to improved time with patients or improved experiences both for patients and clinicians. But if you extrapolate that up and you take the volume of the wider kind of ecosystem across the NHS, then you've got the ability to demonstrate that not only for the immediate organisation implementing, but also the benefit and potential for that wider scalability. I was struck when we were implementing the electronic prescribing, as I mentioned earlier, because I think there were so many different aspects of improvements or and efficiencies that were drawn from that it was even not aware that it would have the further impact of up to 70% reduction of handover into primary care, as an example. And also the timeliness, therefore, for patients accessing their medication. So I think in terms of that ROI, you can put a monetary value against it. You can certainly demonstrate the efficiency and the potential scalability of that efficiency if more widely adopted. But also, I just think it's important not to lose sight of the social impact.
Yeah, no, absolutely. And I don't know, Nick, if you want to come in and pick up on that point specifically. I think that's a really important one, and we've been touching on it, haven't we?
Yeah, I think there's so many kind of factors, especially with more technology coming in, and people, if it's useful, like you say, if it's useful or usable, people will use it. And we know with kind of with Teams, Copilot, ChatGPT, whatever systems people are kind of using in their day-to-day, there's going to be additional costs or things that aren't necessarily factored in. So the kind of model around the way that I guess trusts and organizations buy products potentially looks like it's going to be changing, because if you look at like a small AVT type company, they're going to have to manage the cost of actually 20% of their trust using it versus like 80% of the trust. The amount of uses that they're going to get of the kind of tool is going to be very different. So the cost model is something that I think a lot of people are kind of looking at the moment. I think I'm just going to touch on like an aspect that was brought around the kind of designing UX, if that's all right, around I think it goes back to this a step before that, and it's something that I've been challenged on recently, and we've got a system engineering kind of team, and what they always challenge me on is actually, do we really understand? Can you understand what's going on, what's the problem, and what you're trying to solve? And I think with all kind of business cases and everything that we're doing, is by being busy and doing something, it feels like we're progressing and we're making progress and we're sorting a situation out, whereas actually we don't take that time to actually really understand and go through what's needed, so we can design something that is suitable for now but also has the right foundations to then build on, so then it's future ready for the next iterations. And then we're kind of duplicating, because we're kind of like, right, this new thing, let's do our tick box kind of designing, go through our care pathways, let's do X, Y, and Z, but it's not thinking about it in that system view. And obviously with neighborhoods and the way that we're working, looking to change, we need to, I think, probably take a step back before we take a step forward. And it might feel like we're slowing down slightly, but in the long run, it will speed us up. So that's what I've been personally challenged on the last few months, and getting a team to kind of help me work through that has made a huge difference for me.
There's something really, really important there, isn't there, about future proofing, because you kind of don't want to, what you don't want to do is to innovate for your problems today. Not to say that moving forward and optimizing and bringing in new solutions shouldn't help, because of course it should help to make things better, but you want the foundation to almost be on the future as well as the present, so that you're able to be less reactive and more proactive as you move forward.
How do we factor that in? How do you factor that into the return on investment of business cases?
Because you don't know what you don't know, but what you do know is that every year there's a winter pressure, every year patient numbers are going up, et cetera, et cetera. So there is something about a strategic planning aspect to that, isn't there? But that's definitely not today. I feel like that could be a whole white paper in itself, to be honest.
The only other thing I have to say is, and I'm sure there's people on the call, is that a lot of time when you're working clinically, you get given a system and you're like, make it work, make it successful, and you haven't been involved in any part of the process up until then. So it's making sure that you're getting the right people and roles involved from the start, from the end-to-end process. And that needs to be factored in, not just the monetary values. It needs to be factored in too, because it delays things, the adoption's slower, it affects clinical risk, all sorts of things. So yeah, absolutely.
And I was just going to come back to Paul actually and say, ask you, Paul, what does good actually look like from both the frontline and a patient safety perspective, and our organizations actually measuring the right things. Just before you answer that question, I just also want to read this comment from Yvonne, who says she'd be curious as to how involved clinical teams are in the digital system procurement, because They should be involved in evaluating vendor options before vendor selection is done. It sets the tone to what potential engagement could, maybe be moving forward. So I feel like those two, that comment and that question are kind of linked, isn't it? Because it's, what does good look like? Is it that people are more, from the front line, are more involved in the conversation, and in order to measure the right things?
Yeah, I mean, I think, well, I think if I had a magic wand, let's put it that way, I think it would be two-pronged approach. I think for clinicians, and we've touched on this as well, haven't we, around systems that are intuitive, easy to use, extremely usable on the shop floor, minimal duplications and workarounds that we often have to find as clinicians in busy environments. And just, I suppose, decision support tools that are just helpful, not, intrusive in terms of our day-to-day working. And then coming, last but not least at all, patients. I think consistency and safety of care. Again, there's lots of variation in that throughout different parts of the UK. I think other things like reduced delays, errors, but I think overall that end-to-end patient experience, particularly joined up really for patients that cross different services. And so, yeah, I think in terms of measurement as well, we often measure, as we said before, activity, time-based services, usability, but we should be measuring safety indicators, those clinical outcomes from that clinical perspective. And as we've touched on as well, that UX design, so user confidence and cognitive load, which again, when you look at the evidence base for it, particularly around systems thinking and adverse event review, the use of EPR platforms and technologies does have an impact on the outcome for patient care. Thanks, Hadley.
Just going back to where we started then, Paul, actually, with optimization versus innovation then. So does doing that, which I agree with, by the way, I mean, it makes absolute sense, but does doing that enable more optimization or more innovation?
That's the $1 million question.
It is, isn't it? Does it give you what does it give you? Because obviously measuring all of that, and we know that from within HIC, it's difficult, it's hard to get the data, it's hard to sometimes put those tangible benefits onto the page, so how does one marry the other,
Yeah. I think it's just trying to balance it. Again, it's that kind of almost, failing. What do you have to do? Fail fast, learn quickly. Again, so it's really just marrying up both optimization and innovation and doing them both at the same time. And I think if organizations and suppliers can do that at the same time, we'll be winning.
Yeah. David, any thoughts on that as well?
Sorry, I missed the
Well, just in terms of, does measuring those benefits actually enable optimization and innovation? Because you now know what kind of good looks like or what good is looking like, but recognizing it's very difficult also to sometimes track those benefits as well.
Yeah, I think so. As I mentioned earlier, I think measuring the impact can be challenging, and obviously the timeliness of that, where I mentioned that it's taken years for innovation to land, etc. So short answer, yes.
Yeah, no, thank you. And Nikki, any kind of thoughts on that in terms of what good looks like and how we kind of bridge that gap?
I think we've seen there's always pockets where what good looks like, and it's when you're working as a multidisciplinary team, you're bringing people in early doors and you understand what you're doing and what you're trying to solve. I think there's a factor that is probably something that from a clinical safety perspective that I'm kind of keen on looking at, is that human factor angle as well around. So when we're bringing in technologies that do summaries and things like that, how do we create that safety net from a human factor, and how do we protect both the patient but also the clinician? So I always got taught, when you're checking a drug or anything like that, you never say what that drug is. You always, because if you say something, you're putting that view onto that person will see potentially what you say, especially when you're in a rushed environment, and you have your steps that you do to create your processes to make sure that you're doing everything safely. Even if you're tired and an emergency bell goes off, you get distracted by something, so that you make sure that you're doing the right thing at the right time. And I think that's at the moment missing from what good looks like. So I would say that's something that we need to do but also from a clinical and a organisation perspective is really work with the supplier side around how do we solve these problems together. And I think what I've noticed in the last few years, especially, and working on both sides, but not for working with like different products, is that they really are keen to work with everyone to try and get the product. They want their products to work really well, but there's not the headspace or the time or the right people to bring in or the right funding necessarily to be able to do the things that will make the big difference. So it's trying to get that balance to get it where it needs to be.
Tricky balance, isn't it? Tricky balance. Like we said before we met, folks, 55 minutes has flown by. We've covered a lot there. I think there might be just a few slides for us just to kind of finish off, but just to say a premature thank you. So for everyone on the call, we would love for you to join one of our specialist interest groups that form part of the EPR network. These are NHS led, attended and run. It enables you to connect with clinicians, leaders, tech providers that are part of the network and help to influence, you know, the design, optimization and safe use of EPR systems and drive those innovations and improvements. There are, you know, lots of groups to be involved in, including maternity, paper to digital and others. So please scan the code and come and join us. So thank you for that. And then I think the next slide is just a reminder, if we could move the slide, thank you, of the regional summits that we've got coming up. So it'd be great to see you in Scotland in September, Ireland in October and Wales in November. So come and join us for that. It would be great to see you. If you want to connect with myself, David, Paul or Nikki, you can do on email, or obviously connect with us on LinkedIn. There are our email addresses. Feel free to reach out. So obviously three sets of thank yous. Thank you to our panelists, to Nikki, David and Paul for your contributions today. Thank you to everyone, of course, for joining and taking the time out. And as I said before, if you're able to join one of our other sessions, please do so. And of course, a big thank you to the HIC team that have been working for a very long time in the background to make today possible. So Colleen, Rhiannon and Charlotte, thank you so much for all of your efforts. Couldn't have done it without you guys. So yeah, thank you so much for your time today. And we look forward to seeing you again. We've got 5 more over the next few days. So hopefully we'll see you guys then. And Paul, Nikki, David, anything that you want to say? We've got 2 minutes, so feel free to say it, or we'll give people a few minutes to go and catch a brew.
Let's do that.
Awesome. There you go. You said it for us. Thank you. Thanks so much, folks, and look forward to seeing you soon.
Good to see you. Thanks, folks.
Thank you.
Take care.
Bye-bye.
Bye-bye.